Perfect. Welcome everyone to one more journal club. Today we're going to be talking about cortical correlates of pain relief, and we'll have here Dr. Benedict Alter with us. This journal club is presented by NIRx. We are an FNIRx manufacturer, and we like to follow our users and know about their great ideas. Today we'll talk about one of the growing fields, actually, which is the use of FNIRs in the clinical applications. So I hope you will enjoy. The webinar or the journal club will be moderated by me and Alina in the background. And just some considerations before we move on. So you are all muted. Questions are welcome at any time. You can use the Zoom chat, and at the end you can also unmute your microphones and talk if you would like to. All the content will be available on our website in the upcoming days. And if you have any further questions on our solutions or any specific thing, you can also send an email to us at consulting@nirx.net or support@nirx.net. Okay, so I'm going to present Dr. Benedict Alter that's here today to share his paper with us. Dr. Alter is a physician scientist practicing pain medicine and studying pain modulation in an effort to improve pain management. He's an assistant professor and director of translational pain research in the Department of Anesthesiology and Perioperative Medicine at the University of Pittsburgh. Research projects focus on the role of endogenous pain modulation in chronic pain and identifying ways to leverage pain dampening systems for novel pain therapies and biomarkers. Thank you very much, Dr. Alter, for being here today. And the floor is yours.
Thank you so much. That's it's an honor to be invited. I'm excited to talk about our paper. I even see my co-author, Hendrik Santosa, is on the line. He's like a rock star. So we might need to get him to weigh in on some of this too. But let me go ahead and get my slides up. And I want to also leave plenty of time for discussion and questions at the end. So let me see here. Can everybody see my screen okay?
Yes, we can see.
Wonderful. So as we were talking, I have an interest in pain research, and I'm actually relatively new to the FNIRs field and found it to be a really fascinating technology that has, I think, a huge potential for clinical and translational research. And so that's kind of where I'm coming from. And I'm excited to share some of the what I would call almost like a preclinical study, looking at some of the tools that I plan on using for more clinical translational research applications. So this is the paper that I'll go through. I'd like to first, since I think most people in the Journal Club have some familiarity with FNIRs, I'll talk a little bit more about pain and pain research for a few slides, and then review our results from the paper, and of course have time for discussion at the end. So just some very basic concepts related to pain. So this is, my sort of a stock slide, which is pretty common to see in most pain talks, about the pain sensing nervous system. And that is this concept of nociception, or detection of potentially damaging noxious stimuli, or they're noxious because they're potentially damaging to the peripheral tissues. This occurs, in like the skin, for example, with different afferent fibers. So you can see here that in this cartoon, there's small diameter fibers, which are relatively high threshold for noxious stimuli such as heat. And then also, low threshold fibers like A beta fibers, transduce, light touch. And this transduction events occur in the periphery in the skin. They're transmitted along peripheral nerves, going to the spinal cord, and then ultimately up to the brain. So this is kind of the ascending nociceptive system, and that's of course very important. But one, I would say, probably equally important system is the descending modulatory pathway. And that's where there's top-down modulation of these incoming signals, even at the level of the first synapse in the spinal cord. And just to kind of highlight a couple common areas that are involved. So I mentioned again, those ascending nociceptive fibers coming in into the spinal cord here, shown in pink. There's a synapse, and then in the dorsal horn, of course, some processing in the dorsal horn, but there's this sort of classic spinal thalamic tract, which sends projections to the brain, thalamus, and then other areas which are important, both cortical and subcortical areas. There's also, as I mentioned, the descending modulatory pathways, and in this figure from this review, which is actually very nice and still pretty relevant, there are both inhibitory and facilitatory descending modulatory pathways, here shown in green and red respectively, which go from cortical areas to midbrain and brainstem down to the spinal cord. So why is this relevant? Why do we care? Well, it turns out that there is a hypothesis, at least, that there's an imbalance between descending inhibition and facilitation that probably occurs sort of naturally in a population, but that it may be a risk factor for the development of chronic pain. It may perpetuate chronic pain, and it may also be a biomarker that could be leveraged to identify appropriate treatments for patients with certain types of pain. And the animal data for that is growing. There are animal models looking at these descending modulatory pathways, and they found this to be at least some evidence supporting this imbalance hypothesis in different types of pain. So whether it's from nerve injury like neuropathic pain, or more like what we call nociceptive pain, where the nervous system is intact, but you have incoming pain signals from joint degeneration, such as in osteoarthritis or rheumatoid arthritis and inflammatory arthritis. So there's evidence in the animal models. Human research and clinical research is, of course, a bit more difficult in a lot of ways, definitely relevant to clinical practice. And the current tools have been quantitative sensory testing, and that's where calibrated either painful or innocuous stimuli are applied, and we ask participants to kind of rate them in systematic ways, almost like a vision test for pain. And then there's also brain imaging and EEG, that each has its limitations, right? And I think it's probably been mentioned at prior journal clubs how MRIs have limitations of cost, availability, ecological validity can be a problem, and then the other problem for my research is also there's a potential confound from distraction. And so distraction can actually engage these descending inhibitory pathways, and that may make studying these quantitative sensory tests a little more difficult than with FNIRs. So I wanted to just review very briefly what's been done with FNIRs to study pain. And this is just the tip of the iceberg. I think there's a lot of exciting work from Dr. Becerra, Dr. Borsuk's group, and probably several other groups that I'm just forgetting to mention. But so I hope that you don't think this is a comprehensive review of pain research with FNIRs, but I think it just shows that this is a growing area. One of the earlier papers is from 2008, where NIRx was used to image cortical responses to painful heat versus innocuous brush. And these were 5-second stimulations in healthy participants, or a relatively small number of healthy participants. And there was actually a pretty robust change with this, these sensory stimuli. And it seemed like there was a difference between the innocuous and the more noxious heat stimulation. And that's what's shown here. So if you look here on the top row, this is part of their head probe that was positioned over the somatosensory cortex. And then on the x-axis, these are measures of oxygenated and deoxygenated hemoglobin every second. The yellow bar here is that 5-second stimulation period. And you can see that, and then I should say the red and orange are contralateral and ipsilateral cortices. And there's dynamic changes that are, seem to be occurring, more so in that contralateral somatosensory cortex, which you might expect, although this occurs bilaterally. And then in the sort of the frontal region, so there was a probe, sort of a grid bilaterally over the frontal cortex. You can see that with brush, there was sort of a dynamic change that sort of was occurring both during the stimulation and then sort of after. And that the dynamics of that were actually pretty different with the painful stimulation. So there was actually this initial negative deflection with pain that you didn't really see with the brush. And this was pretty exciting, I think preliminary, but pretty exciting. And there's been subsequent studies which showed we're I think a little better controlled from the quantitative sensory testing side, which confirmed, that there were cortical changes to these 5-second noxious stimuli. There was a study done with Dr. Borsuk's group looking at this frontal response that appeared to be responsive to morphine, although this was, again, in a relatively small group. So I think, this exciting but relatively preliminary results. And then I think really also exciting first steps looking at what we would call clinical pain, although, it may not be like what everybody thinks about with clinical pain. Actually, these studies were looking at the noxious stimulation associated with surgery. So patients were getting cardiac ablations of arrhythmias. And so this is like a visceral type pain due to the ablation of heart tissue, essentially. And they did see some activations that were occurring in prefrontal cortex, sort of, especially this frontopolar medial prefrontal cortex. And then also this group has looked at noxious visceral stimulation just related to routine screening colonoscopies. And what's really fascinating here is also that these patients are sedated. So it's, in a situation where NIRs might be especially helpful because, patients aren't really able to report pain. And if you could monitor pain under anesthesia, that could be something that could guide treatment, after the procedure. So focusing a little more on the paper, where we come in, as I said, I'm interested not only in this sort of ascending nociceptive system, but also the descending modulatory system. There's a couple different sensory tests which have been studied to look at this system. But the one that we chose is pretty interesting. It's called offset analgesia. And we focused on this because it's actually a little different than some of the other sensory tests. And the mechanisms remain a little bit unclear. So we know that it's, this is, I should back up and say this is how we measure it. So we're using a noxious stimulation of the skin again with heat. And so participants come in, they have actually a calibration procedure where we find a noxious range temperature that elicits a pain that's about 5 out of 10. So it's like a moderately severe pain for 30 seconds. This produces pain. They tell us that by rating that pain on a computerized visual analog scale. And you can see in this figure that in the orange dotted line, that's that 30-second heat stimulus. And this is their pain rating on the bottom part of the graph with the computerized visual analog scale over time. And this is a rating that's done in real time during the stimulation. Offset analgesia is an interesting phenomena because if there's a slight decrease in pain or in the noxious heat, so there's a step down in noxious heat, it's accompanied by this dramatic drop in pain intensity. And so the perceived pain is much less. And you can see that in this black line here. This is that temperature, or sorry, the pain rating of during the offset stimulus. And you can see that drops dramatically. And it's very different than if that stimulation was held constant. And I would point out that, this pain intensity difference occurs in a period of time where the incoming noxious stimulation is the same. So like the temperature here is the same during this period, the perception is very different, right? And so the paradigm uses this offset stimulus, which has a sort of a drop in pain intensity compared to a constant stimulation. And so we use that during FNIRs as a way of looking at correlates of offset analgesia. Some other things that are known about offset analgesia I just listed here. It's again relevant because it seems to be affected in chronic pain states. So getting a little more into the methods section of the paper. So this is sort of the setup from the experimentalist viewpoint. I'm not sure if you could tell who that participant is. The head probe is shown here, and it's using the NIRx Scout 2 system. So we had 42 channels that were long distance, and I didn't go over a lot of the details about FNIRs, but if you remember the distance between emitter and detector, if it's a certain distance, that catches cortical activation, because the light path for longer channels does go deep into the tissues. And that's relevant here because we actually use short separation channels as well. And so, these short separation channels, the emitter and detector are positioned quite close together relatively. That light path stays in the superficial tissues and can be used to control for physiologic noise, which is essentially cardiopulmonary oscillations. And when you're studying pain, it's pretty well established, especially with these acute pain stimuli, that cardiopulmonary noise will change. So there's an autonomic response to painful stimuli. And so you definitely need to control for that. And I think that's one of the the strengths of using these short separation channels. Other things I wanted to mention, you can sort of see the arrays here of sort of this frontal array of the probe, and then bilateral sort of somatosensory cortex. And then the intensity of this coloration shows you sort of the probe sensitivity to these different Brodmann areas. I mentioned a little bit before about the behavioral paradigm, but just to flesh that out, we use again this thermal stimulus from the actually it turns out to be a MEDOC cutaneous thermode, which is pretty standard in the field. I talked about that calibration procedure. In terms of our population, we actually used or we ended up recruiting 24 participants, and this was powered to see a difference in the behavioral paradigm as our way of looking at neural correlates. We wanted to make sure that we had enough participants to see the behavior. As I mentioned, because it was a calibrated noxious stimulus, so that actual temperature varied from participant to participant, which is something to keep in mind. The average temperature that we used for this 30-second stimulation was about 46 degrees Celsius, which is noxious range, although there is significant variability among a given population and what people consider to be noxious heat. The other thing to point out is that we used two different counterbalanced orders of control and offset, and we did triplicates of each condition. The other things to touch on would be how we, after data collection. So, I should have mentioned before that we were measuring offset analgesia and, our constant control condition during FNIRx scanning. So basically it was participants were experiencing the painful stimuli, rating the painful stimuli, and they were getting scanned all at the same time. The analysis is just outlined here. So we used this NIRx analyzer toolbox, which Dr. Santosa, who's here, and Dr. Huppert have worked a lot on, and I think a lot of people in the field use. The way we did the analysis, we did a couple of sort of complementary approaches to look at neural correlates. Modeling our hemoglobin oxygenation, deoxygenation was initially done on first level model using a GLM with FIR deconvolution. We used iterative pre-whitening, and that has been shown to be superior than some other methods as a way of reducing movement artifacts. Although for us, there wasn't a huge amount of that because we had participants who were older, able to stay still. And I think the biggest, thing to note about this study, and something that will plan on doing and would recommend for others to do for pain studies, would be to definitely include short separation channels as regressors of no interest, as a way of addressing that physiologic noise that certainly changes with painful stimulation. To make group level comparisons, we had a fixed effects model using time and stimuli, and robust statistics estimators to reduce outlier effects. So on to the results. It was, it's interesting, and as I kind of alluded to before, before we did this study, not a whole lot of people had actually looked at longer painful stimulation, and that's something that we've seen that we needed to do to look at our offset analgesia paradigm, because typically people use these 30-second heat stimuli. So our initial analysis was just to see what are the cortical correlates of this longer 45-second noxious heat stimulus. And that's what's shown here. So first we looked at activations relative to baseline. And that's what's shown in A. So that's this constant control stimulation at that painful stimulus intensity. So again, the pain was about 50 out of 100 on a pain scale. And you can see that there's activations in the frontal, bilateral, and then also the sort of somatosensory cortices bilaterally. In these plots, I should say that these are channel level statistics. These solid lines represent a sort of a Q value of less than 0.05. So that's Benjamini-Hutchberg correction for multiple comparisons. Dotted lines are hard to see, but they're not significant. And yeah, so that just kind of summarizes these data that you're looking at. And so the top row is the oxyhemoglobin data, and then the bottom row is the deoxyhemoglobin data. So column A here again is that constant control stimulation. Column B is this offset stimulus. And that's the stimulus that should produce offset analgesia. And then this is the entire stimulus duration. And I think the takeaways here again are that there's widespread activation, although there is some regional variation. And when we did a contrast between the two, and this is, again, I should say the whole stimulus, not exactly the area that we're looking at for offset analgesia, we do see differences. And so that's actually pretty encouraging. And that's what's shown here. Now, I wouldn't say that these are the neural correlates of offset analgesia because, again, the epoch of interest here is actually the entire stimulus. To really address, what are the neural correlates, we went on to use this temperature-defined epoch of interest, and that's shown in yellow here. Again, that's after that step down in stimulus temperature. So it's sort of this offset of temperature that leads to the decrease in pain intensity. And what you can see is actually some differences between the offset stimulus and this control stimulus. And so in this sort of A column, that's the control, again, that constant noxious stimulation, you see activations in medial prefrontal cortex. So that's actually consistent with, prior research from Dr. Borsik's group. Bilateral somatosensory cortex. And then with the offset stimulus, similar, although a little bit different. When you look at the contrast, some of these differences become a little clearer. And I'll just highlight that with just a little bigger depiction of the results. So it looks like there's a relative deactivation in left and right medial prefrontal cortex, and potentially a relative deactivation in the somatosensory cortex bilaterally. And what's really interesting is that right DLPFC, or dorsolateral prefrontal cortex, was activated more in the offset analgesia group. So what about their pain intensity ratings? This is the behavior that we're looking to study. So it would be helpful if people had offset analgesia in this group. And it turned out they did, so that's the good news. This is one of the figures looking at that. Panel A just shows a representative trace from just a single participant, and this participant had pretty significant offset analgesia, although there's variation in this population of 24 healthy volunteers. And you can see this black arrow shows what we're measuring really, which is that offset analgesia, that difference in pain intensity between the two stimuli. On the group level, this is different, and that's what's shown here. This is just looking at that sort of minima here of that pain intensity curve. And then another way to look at this is actually just to do a subtraction of the pain intensity curves. And that's what's shown with a single participant in this panel C. So we do see on average a difference behaviorally between these two stimulus conditions. And if you start looking again at sort of the population level variation, it's interesting. It sort of fell out that there were some that had pretty robust offset analgesia. So this is more negative. So they had a bigger drop in their pain intensity with that offset stimulus compared to some who didn't have very robust offset analgesia. And it fell along the median value, actually. And we sort of used that along with sort of the temporal dynamics of the pain intensity curves to define what we would call our behaviorally relevant epoch of interest. And so in that relevant time frame, we get similar findings. And this is, again, just sort of a complementary analytic approach, which showed, again, this significant activation of right DLPFC along with some relative deactivations. We also did a region of interest analysis. And so for this, we had selected sort of a priori, and also, based on where we were putting our probes, what we thought were relevant brain areas based on fMRI data. And then we combined channel statistics, sort of using a weighted average over time in order to do this ROI analysis. And this is part of, the toolbox. So these values are based on projected weights into these Brodmann areas, which I've shown here. And so what you can see over time is that during that period of that stimulus, where offset analgesia occurs, we actually see an activation during the offset stimulus of DLPFC using this ROI analysis as well, which is pretty reassuring and just another complementary way of looking at it. And then we see relative decreases in activation in somatosensory cortex. And this actually mirrors, especially the left somatosensory cortex, mirrors the behavioral data pretty well. Again, I mentioned that there is variability even in this small sample. And so we were comparing, although this is relatively small groups, now it's N of 12 between each, in each group, 12 with a robust offset analgesia and 12 without. We did see significant differences between the offset and control stimuli. Again, kind of pointing towards this DLPFC area. And that looked a little different than the control group. So to summarize, again, I wanted to make sure we had plenty of time for questions and everything. So I'm happy to review specific things if we do have questions. But to summarize, we saw that prolonged heat stimulation was associated with frontal and sensory cortical activations in this group of healthy volunteers. We also found that offset analgesia was associated with right DLPFC activation, which was interesting and is sort of an area of future investigation. And then we also found deactivation of somatosensory cortex and medial prefrontal cortex. And this led us to a model, which we're testing in healthy volunteers and in patients, where we think that right DLPFC may be involved with predicting how pain evolves over time. And so, pain actually is, and sort of the experience of pain over time is likely related to predictions. And some of those pain predictions seem to affect pain intensity and how it's experienced. And so in this particular model, in the context of offset analgesia, if you have a slight decrease in incoming heat stimuli, so decrease incoming nociceptive input, that decrease is, for lack of a better word, maybe sensed in the DLPFC. That leads to a increase in descending inhibition. We think that pain isn't really as much of an issue. We don't have to worry about it. That gets filtered potentially in the spinal cord dorsal horn, and that leads to decreased activations in other parts of the cortex. And this is for certain a simplification, but this is something that we're using to look at in other studies. I think there's some pretty exciting future directions for FNIRs in pain research. I spent some time talking about how pain monitoring could be something where FNIRs is involved in that. And this is not just in the OR, could be something that occurs in the ICU, in sedated patients. This could be in other contexts. For patients who are able to report their pain, I think it's still potentially very relevant if it reflects physiologic changes occurring to this descending modulatory system, or even the ascending system. And so if we can understand some of the variability in those systems, on a physiologic level, that could help us in identifying mechanisms from patient to patient, but also pairing the patients with appropriate treatments. And here are my references in case you want to do some more reading, but of course, happy to discuss, and please reach out to me if you have any questions. And of course, I'd like to answer any questions now. So thanks for your time, and I hope that was interesting.
Thank you very much, Dr. Alter. It was definitely very interesting. I don't know, before going to questions that we had before, I don't know if you here have any questions to Dr. Alter. Okay, you, Cecile, feel free to open the mic, or you can write your questions on the chat.
Thank you very much. First of all, thank you for the wonderful talk. I was wondering about the deactivations that you observed. Can you tell us a bit more about it? What is it exactly? What do you, in terms of hemodynamic response? And yeah, how, like, I'm just curious about it.
Sure. For our initial analysis, we looked at both oxygenated and deoxygenated hemoglobin, and so I guess I'm referring to activations as increases in oxygenated hemoglobin. How that all lines up with neural activity, I guess, is an area of research, but I think that's pretty established that you have this hemodynamic response function, hemodynamic response rather from neural activity, and so we're kind of capitalizing on that to see these cortical changes in blood flow potentially representing activations of those cortical regions. But certainly it's an area where we're not exactly sure what's happening like on the neuronal level, but we sort of make that extrapolation.
Thank you. We have one question in the box here. How would meditation affect this pain pathway, or maybe any altered conscious state, I would say?
That's an excellent question. Yeah. So not as much has been done with FNIRs as other imaging modalities. Different medications used clinically for pain certainly affect these brain areas and both the ascending and descending system. So, for example, opioids like morphine, infusions of opioids, which are often used in sort of the research settings, such as like remifentanil. These tend to decrease cortical activations that have been associated with either acute pain, or typically it's acute pain. The neural correlates of chronic pain are a little more unclear, even with fMRI and PET imaging. That's one thing that's sort of an advantage of FNIRs actually, is that we could potentially have participants, they're actually doing some things that trigger their chronic pain, right? And we could potentially see that with FNIRs while they're doing it, as opposed to some of these fMRI designs where you ask patients to just report spontaneous chronic pain, or you have them do an exacerbating physical maneuver and sort of do a pre and a post scan with fMRI. Other medications have not been as widely studied. Anesthetics probably have an impact. I mean, they certainly have an impact on consciousness, and I'm sure they would have an impact on pain-evoked activations or deactivations. And actually, the Dr. Borsik's group has done these studies of FNIRS activations during general anesthesia, and so how that system gets affected by general anesthesia, and then how these sort of potentially analgesic drugs overlay on that, I think is a really fascinating area of future work, and is in no way well established. So I think stay tuned, or maybe that's an exciting area that you could go into.
Thank you very much. Yeah, definitely a very interesting area when it comes to this perception, first person perception. I saw in your study that there's a lot of variation as well. I'm very interested that you try to kind of separate into groups to see if there is any way you could group the responses for that groups as well. Could lead to some correlates that's different somehow in one group and the other. Very interesting. We have a question that came before, just talking about what kind of pain is detectable with FNIRs. I think you talked a little bit already about this, but is anything else you'd like to explore on this?
Yeah, that's a great point. And I think as just coming from the pain research world, the thought is that there's probably potentially different pathways depending on some of these sort of types of pain, right? And so the model that I've used is engages the somatic system, so that's really just, cutaneous afferents to the skin, for example. And that may actually be a different but overlapping system with visceral afferents, right? And so visceral being like the nerves that are and nervous system that is sensing function in internal organs. So and that may, so that's like for example, some of the work that's been done on pain response during colonoscopy. So part of colonoscopy is a distension of the colon, because they need to, have the camera be able to see the colon. So they actually insufflate. This is done during sedation. So, people don't really experience it, but during the sedation, people can have some grimace and some response, right? So they're not totally, lacking a response to this insufflation. And so, what this Dr. Becerra's group and Dr. Borsick found is that there was some medial prefrontal cortex activation during that insufflation event that correlated with the facial grimace. And so that's an example where visceral pain could be potentially detected. Although, again, is that, there's this time correlation. We don't know exactly what those activations or hemoglobin oxygenation changes are, how they relate to the perception of pain. Certainly the participant or the patient in that case is not perceiving pain because they're not conscious, but they are responding, but with a facial grimace. So it just highlights, I think, some complexity of researching pain. So that's visceral pain. We talked about somatic pain. The cardiac studies I mentioned, kind of fall into this visceral pain. Chronic versus acute pain is another big distinction. Acute pain is, at least I've been talking about acute pain where it's a discrete painful heat stimulus. And that is probably different than chronic pain, when someone is suffering from chronic pain for months or years. And certainly their brain activations, resting state activation with fMRI is all very different. There's differences even in anatomically with different tracks become different, different in chronic pain states. So I think that's another big difference that is worth remembering, that acute versus chronic is different, somatic versus visceral. Typically in chronic pain, you can have neuropathic, which is like nerve injury type pain, that tends to be a little different. And so and then the other thought is, headache is a whole different area, which I think could be used with FNIRs. And I'm trying to remember if people have used FNIRs to image migraine or a headache, but that could be a really interesting area as well.
True. We had a recent paper with migraine, trying to, I think it's the first one I've read actually, so trying to see that. Also chronic pain, I think it's a very interesting research area. In what you said about, even if you have a chronic pain, sometimes this chronic pain becomes acute at some point, and then at some level it becomes lower again. So it's actually very interesting because chronic pain kind of changes your somatary sensory system as a whole, right? Your thresholds become different. So very interesting indeed. Do we have any other questions here? Okay, there's one more question that came in, I guess, more to us. If we have customers using our devices in medical settings, as you can see, Dr. Alter is one of the examples of that. We do have other researchers using the devices in clinical setting, even though the device itself is not a medical device. That's very important to say. It can be used in clinical studies, in clinical research. So many of these examples that Dr. Alter already said, we do have other customers using. If you are interested, just let us know. Okay, I guess we don't have any other questions. Dr. Alter, thank you very much for your presentation. It was really nice to see your paper and talk a little bit about it. And we are looking forward to your next publication and next steps on the pain research. Thank you very much.
Thank you so much.
Bye.